Hi, my name is Orlando Alvarez, and I would like to thank you for joining us at Dental XP. The subject that I would like to share with you all is immediate tooth extraction, immediate implant placement, and immediate load-use and guided surgery. This specific topic is not well explained, even more some of the people says that you cannot do it. I will show a way to do it, and the system that I use to perform it is Novel Guide from Novel Biocare. We all know also that this kind of procedure needs a CT scan procedure, and we all know that we need a specific protocol. The specific protocol of Novel Guide is a double scan. One scan for the patient with a radiographic template with some good aperture marks, and a second scan only to the radiographic template. Sometimes we do an extra CT scan. Well, the problem is that the unnecessary amount of CT scan, it might be more than 30% in the United States. So we have to be very careful to avoid this situation because, of course, we do not want to cause excess of irradiation to our patients. We all know that it's not a benefit to do excess of radiation to our patients, and we have to, of course, as I said before, avoid this situation. But how can we do this? How can we do exactly what we want to do to our patients? Avoiding the excess is the thing that I will teach you and I will show you step by step in the next 15 minutes. So the first part could be a little bit not very interesting, not so entertaining, but I will try to explain you very quick. So let's talk about the system. All the principal characteristics of the system are, of course, diagnosis, planning, and in the case of Novel Guide, planning based on the final rehabilitation. That will give us a lot of information related to the relation between the bone and the teeth. Of course, the next step is surgery. Surgery that will be performed flapless, with all the benefits of a flapless surgery, with the safe position, the implants, in the ideal position related to the teeth or the tooth. And of course, in case that the patient or the case allow us to install a final prosthesis, we will do it. It will be temporary or it will be definitive. It could be cement retained or it could be screw retained. So it will be our decision. The system will not do any proposal. Let's see this particular case that it's a classic case situation if we want. It's a partially edentulous patient with absence of premolars and molars. That is the classic class 1 of Kennedy. And all the experienced dentists know that this kind of patient needs implant. But how we face it? This patient that is wearing a partial denture and is a remaining portion of teeth, how we face it? What do we do first? We do first the extractions. We do first the teeth, the remaining teeth treatment. Do we have a chance to preserve the mouth? Do we have to do the extraction? Do we do the extraction and the immediate implant placement? Do these patients want to be fully dentulous for a while? For a period of time, for a short period of time, for a long period of time? Do these patients want to wear a full removal? Can we do it guided? Oh, there is a lot of questions. Of course, there is a space that we can suppose that we can install implants, as we are seeing in these circles, in this red circle. But the problem is that we have to perform a CT scan. Well, this is all about it. What we are going to do is a little simple trick. The little simple trick is what we are explaining. We will do a radiographic template as a partial case, like we are doing right now, but in the third portion, we will not cover the tooth, as the protocol says. This situation will lead us to do a cast articulation in the articulator. We are seeing in the rounded yellow the good aperture marks. And the thing is that with this modified radiographic template, our patient will go to the first CT scan. Remember, that is a partial radiographic template. We will let us to our patient go to the first CT scan with this, and then it will come back. It will be articulated in the articulator, and of course, we will treat this after the CT scan when it's out of our patient, of course, as a classic prosthesis procedure in the lab. In the red X mark, we are going to extract the remaining teeth, and we will follow the green lines of the contour, of course, in this particular case, guided by the articulator. We will softly, one by one, make the extraction, and we will transform this partial template in a full template. Very soft and very easy, till we complete our work, of course, guided by the articulator. When we have already done this full transform of the partial radiographic template to a full case radiographic template, in that moment we will take the second CT scan. And it is possible? Of course. It's absolutely possible, because there is no need to do immediately. I mean immediately the first CT scan, the patient wearing the radiographic template, and then the second CT scan only to the radiographic template. So we have a full or complete radiographic template. So where's the trick? The thing is that we can do a second CT after a while or hours of days, like I said before. But the important thing is to preserve the good aperture points, to be able to overlap this information in the electronic model. So we have the patient, and right now we have our 3D model, make it electronic. Then we have the radiographic template, a full case, but it belongs to our patient, that is a partial case. The relation between this is the same, but right now we are seeing a new image, a very important view image. This is the image that will let us do a perfect planning, because the light blue image is containing all the rehabilitation that we plan in the articulator, and we can see it in electronic way. This situation of a full case, of course, it will match with this partial case, because it's the same patient and we do not do any alteration to the good aperture marks. Okay, so now we are able to see how will be the final rehabilitation and where are our teeth right now. This is a pathological situation, because due to the bite forces and the lack of bone surrounding our teeth, the teeth are going or moving to the buccal aspect and to an apical portion. So what we are trying to do with this is to mark the spaces that we will need to install our anchor pins. That is very important to do a guided surgery. In this image that we are seeing right now, we are seeing the contour in yellow of our bone. The system and all of the computers and all of the system will allow us to see how much bone do we have, how much quantity of bone do we have, and how is the quality, because of the health field unit, those things. We can measure, we can take some measurement, and we can relate it to our present teeth and to our future teeth. The future teeth is the ideal position. So in red right now, we are contouring the present position, the pathological position, and now we will contour it in green, the ideal position. With that information, that is very important, we can plan our treatment, and in the future, of course, we can perform the procedure, a guided procedure, because we can overlap the situation electronically. Physical is impossible, but electronical, you are seeing right now. Maybe we have a problem, a little problem. And the problem is that we have a gap, a little gap between the bone, that is yellow, and between the future surgical template. This gap, we will never know it how it is, because we have soft tissues that will heal, and we don't know, and we cannot anticipate this situation. But we can do something to prevent or to have an action in order to reaction and have a very good implant procedure. Right now we are seeing the full template, the new model with the implants, and of course the surgical template. The surgical template that in some of the spaces or some of the portions, it will be after immediate extraction. We all can remember right now that in the anterior zone there are some teeth that will be extracted. So right now we are prepared to go to the surgical procedure. This surgical procedure should be very soft and very easy. This is quite important. Why is quite important? Because the surgical procedure will let our implant heal in the best way as we let them to do it. So there will be some implants placed in immediate extraction socket, and some socket will be filled by grafting material. After that, of course, as we are seeing right now, we put the surgical template and we install the implant as the classical way. Here you can see the grafting material in the socket, and of course the implants installed in the socket and some sutures, dots, that are doing to prevent some situations with the soft tissue, and of course to have the best healing that we could have. We don't have to forget, we will never have to forget that everything that we do to preserve soft tissue and bone is to preserve the osseointegration. Right now we are seeing the prosthesis that we will install, and the green arrows are showing this zone that we don't know what will happen, this unknown healing zone. This process is scrutiny, so we already knew that it will have a gap between the prosthetic contour and the gingiva, and we have to prevent to our patient for this situation. Right now, the final result that you are observing with this gap and this situation between the gingiva and the teeth, a little of bleeding, classic, through the whole of the anchor pins. And we have, of course, the image of the situation of our patient before the procedure and after the procedure, 1 hour, that's it's called teeth in an hour, and the radiographic check, that is very important. Panoramic view, when we able to see the relation between the implants and the prosthetic structure. And after 6 or 8 months of healing, we are able to see, of course, in these green lines, the gap and the unknown zone. What is important? That we prevent this situation to our patient. That this thing will happen. That the gingiva will be remodeling, and after 6 or 8 months, as I said, it is complete. Now we are able to do a reline procedure. But let me show you this with this yellow arrows. This is the place where we have a socket that we fill with some graft material. This is the place when we do some suture, and of course you can see all the implants. And there is no thinking of that something is going wrong. We take our prosthesis, and of course, right now, we go to the procedure. For that, we need a tray adhesive for silicones that we will paint the internal part of our prosthesis, the one that is related to the gingiva. And the thing that we will do is a classic reline. We screw it in position, and we move the lips, everything, to mark all the lines, and we send it to the lab technician. We cover the abutment with the helium abutment cup, and after a while, 8 hours or something like that, we receive back our prosthesis, everything rounded, everything very contoured, very clean, and of course very polished. Now the relation has changed in a complete way, a better way, a nice way, and of course it allows us to give a final prosthesis to our patient, even though we can thought it was temporary. Our patient received it with a very, very satisfied experience, and of course the final result also led us him to smile in a better way, to feel comfortable, and to feel very predictable about his teeth. That's the things that I want to share to you. I think that it is very clear, very easy, and now you are able to perform guided surgery in those cases that you have to do immediate extraction. Thank you for meeting me at Dental XP. Bye.